Thank you very much, friends and colleagues. We already have a number of our colleagues online, so we should begin promptly, although we know that for those who are in the building, it's always a bit of a challenge to juggle people getting lunch and coming to the session. So we'll also expect some people to join us as we go. But we do have a large number of our country officers online, and I'd certainly want to welcome them. I'm Michael Bartos from the Science for Action division at UNAIDS. This is one of our series of seminars that we have as part, basically, of a process of bringing, I guess, to our attention, to the attention of our partners, key pertinent issues in relation to scientific advances in relation to HIV. And the brief that the Science for Action division has within the UNAIDS context is partly how can we best translate scientific developments into policy salient and actionable items at countries. And so that's the sense in which the information and discussion we'll be sharing today is part of that, as well as colleagues who are presenting here from co-sponsors and partners, from UNICEF, World Health Organization, UNITAID. We're also joined by other colleagues here from International AIDS Society, Medicines Patent Pool, the Ecumenical Advocacy Alliance, and I'd certainly welcome all of you. Our intention is to certainly make sure that these discussions are collective and shared ones. So that's really just by way of introduction to the discussion. The topic we have in terms of paediatric ART, I think it reflects a sort of there's an interesting paradox. In the AIDS field, quite often people sort of say, oh, well, children and AIDS, that's the easy issue. Kind of anyone will give money for that, anyone will do stuff on that. It's kind of very straightforward. But the paradox is that we know that children are actually less treated than adults, in the same way that we also know that pregnant women, in fact, find themselves, despite all of the emphasis on PMTCT programming, find themselves less accessing treatment than other women. These paradoxes are ones that, I guess, reflect some of the difficulties and some of the real challenges in terms of making progress in this area. So that's, I suppose, just one of the reasons for the pertinence of this topic. But with that, I will hand over to Karusa Kiragu, our Senior Advisor in Maternal and Child Health, who will introduce the participants and conduct our discussion for today. So over to you, Karusa.
See if I can do this right. I think I got it. So thanks, everybody. I'd like to welcome you, and I know there's other viewers, as Michael has indicated, on the web, and we welcome those as well. We have 4 colleagues who are going to, 3 other colleagues that are going to be presenting this discussion around pediatric treatment. For us in the global plan to prevent new HIV infections among children and keep mothers alive, one of our very, very focused goal is ensuring that the children that somehow escape and become they acquire HIV, that they are also getting treatment. It's part of the component. It's the 4th prong of PMTCT. So it is really a very integral part of the work that we are doing in the global plan. I think, well, just a little bit of housekeeping, and I'd like to thank Celeste very much for organizing this, and I know it took a lot of work to herd the cats together here. What we can do is maybe just we'll have all the other speakers present, and then maybe we shall have a question and answer session. But I'll quickly do a small introduction. And this is what we know about pediatric infection among children. We know that we've got, for children under 15 years of age, we've got about 10% of people living with HIV are children, so the 3.3 million children currently living with HIV, and we know the bulk of these are in sub-Saharan Africa. And we know that about 230,000 died in 2011, which is the most recent data that we have information, the most recent year that we have information on, and newly infected, it was about 330,000. We know that the number of children living with HIV continues to increase, which is good because it means that they are accessing treatment because we do know that infections are declining, and I'll show you that in a little bit. But it's also starting to plateau, which is also a very good sign. The idea is for it to plateau and then start going down. But the fact that it's going, that it's increasing, might be a reflection of the fact that more children are on treatment as well. And this is the happy news that we always turn to Mary May whenever we want to know what's going on in terms of our global plan goal to eliminate new HIV infections among children. And the most recent year, 2011, that we have data for shows that we are somewhat on track. We are hoping that the 2012 data will be equally encouraging. But we feel that we are making some good progress in terms of reducing number of new infections among children. But still, every day, 630 children under 15 die from AIDS. And a lot of these die because they don't have the treatment. They don't have access to treatment. And this is it's really unconscionable. When I look at the statistics that we have showing the proportion of children who are, or the proportion of adults who are on treatment, or the proportion of the population that's on treatment, or among those who need treatment, it's encouraging to see that indeed the curve is moving upwards. Now as more and more people are accessing treatment. But my question has been whether this includes children. Are we on track? Although we say we are on track to reach 15 million people with antiretrovirals by 2015, are we on track to reach children as well? And I think that's a question that we need to interrogate. We need to take a look at the data and pay attention to it more. As Michael was saying, children are less likely to receive treatment than adults. We just have this graph to show that many of you are familiar with, whereas I think this is for 2011 data. 58% of adults who needed treatment received it. Only 28% of children received it, so half as likely. And I think that is what has been galvanizing us in terms of drawing attention to these gaps. For the global plan, which covers 22 countries that many of you are familiar with, we present here countries that have data comparing the proportion of women, pregnant women who are receiving treatment versus children. And this is now treatment for their health, not prophylaxis. And you can see I've circled there the countries where there's some sort of parity, even if not exactly, between adults and between pregnant women and children. And you can see it's only in 4 countries that you could say that children are as likely as their moms to get treatment. In all the other countries, children are way less likely than their moms to get treatment. And you have to ask, why is this? Is it a data issue? Is it the things about pediatric treatment are complicated, and Lulu will be talking about that. But it does beg us to ask, how is it that we can, that there can be access for mothers, pregnant women, but not for children? Again, just to draw for the global plan, we have very specific targets around reducing under 5 deaths due to HIV by 50%, which is what I've highlighted on the box on the right. And that, for us, translates into 90%, ensuring that 90% that we provide therapy to HIV-infected children. So not just reaching the moms, but also ensuring that we are providing treatment to children. There are a number of issues that we are going to be discussing, and I will be turning it over to Lulu in a couple minutes. Just basically, what do we know about innovation in pediatric treatment? I think what we shall hear probably from Lulu and others is that there's not as much progress in pediatric formulations, for example, in pediatric options as they are in adults. So I think that's one of the areas. We know that if children do not get treatment, they have a very, very rapid mortality, and half of them will die by their 2nd birthday. So there's a sense of urgency for children to begin treatment much, much quicker, perhaps than adults. One of the things that we are finding is that children present for testing late. There was a recent study that was being presented about Uganda in CROI in Atlanta last month, and they were showing that on the average, the children are presenting for diagnosis at 7 months, which means basically you've got a long period of time where the child could have been getting treatment, but is not getting treatment. And as you see, because children rapidly deteriorate, it's much, much important that they get treatment right away. And the other issue that we are going to be increasingly dealing with, we have it, many people are working on it already, but the issue of adolescents and ensuring that adolescents are also accessing services. So with that as a starting point, I'm going to invite Dr. Lulu Muhe with WHO. He's going to give us a presentation on what we know about pediatric treatment, what is coming up from the guidelines to the extent that he can talk about that, and some of the issues that countries have to deal with. So let me see if I can get your presentation up, Lulu. Okay, excellent.
Thank you, Karusa. First of all, I would like to thank UNAIDS for taking this topic up, because it's becoming, for me, a kind of a neglected area, and we're not really putting a lot of effort into it. And therefore, for me, it's very important that we discuss the issues, the challenges that we have to push pediatric ART. So let me also say that my colleagues in the HIV department listed there contributed to some of the slides that I have there. I push this, I think. Okay. Now, first, I think let's get the big picture right, because I think, as Karusa just said, 72% of children who are eligible for ART are not getting it. So large majority of children are out there, they are not receiving ART, and this is by far lower than that of adults. That's one. Secondly, we're doing very well with the elimination of mother-to-child transmission, which means that the number of kids who will be newly infected would get less and less. Of course, we need to remember that we will still have kids who will be newly infected. The third is the fact that pediatric HIV testing and confirming the testing, and then the treatment, as I will go through, is more complex, which will mean that it will require more capacity building in terms of infrastructure, in terms of human resource capacity building. So in a nutshell, as we get successful in elimination of mother-to-child transmission, the argument for advocating for pediatric HIV becomes less and less. It will have less traction, and the challenge is how to deal with a more complex problem with weak epidemiologic basis. I think we need to understand that and put it right on there, because I think it's an important point. I have a very simple schema to go through. First of all, I'll deal with testing and the turnaround time, the delay we have, and then after test result is there available, the pre-ART care period that we talk about, and then the ART. I think this helps us because the challenges are mostly on those steps as we go through the testing. HIV testing is gateway to care and treatment, and the earlier testing is done, the more likely that treatment could be initiated earlier. The confirmation of HIV status in infants and children below 18 months requires, as you know, PCR DNA testing or RNA testing, all of which require, technology, and all of which are generally in countries centrally positioned. Therefore, when we talk about health centers and so on, we require a dry blood spot transport back and forth. There is a point of care test technology, which is a new platform and which will be probably available, but still of limited use at this moment. Now, the turnaround time for DBS results, I will mention that with examples, is roughly around 8 weeks, and that is too long for young infants. Then there are some issues around testing period. Currently, the WHO recommendation is to test at 4 to 6 weeks. but we know that by 6 weeks, 20% of these kids actually die. So we've lost 20% already before testing, and we already said that if we use DBS system, the turnaround time is around 8 weeks. So, something like 50% of those who die in the first year actually will die before we get the result. So that is an issue that we need to deal with. Of course, testing at birth could be done, but that will miss quite a lot of those kids who would be infected at birth, at labor and delivery. Give you some examples hot from last week's meeting in Addis from the ITT. Here is the Nigeria example, for example. You could see that with the number of live births, born to HIV-positive women, 27,000, something like that, only half of them actually get PCR testing. That's really to show already how much you lose. We have Malawi. Malawi is as you know, a pioneering country for implementing B+, so it's a good thing. And they have tagged HIV testing to the B+ work. So early on, they have enrolled a lot of these infants. You could see infants enrolled in care less than 2 months. It was very high, but by 12 months, the numbers are way down. So there is a need even for Malawi to see how we can tag the HIV EID work and enrollment to B+. And I have an example from Zambia, again, presented at the IATT, where they used SMS messaging to report back the result of the DBS test, and that reduces the duration or the turnaround time by half. So this is one simple technology, not inexpensive, but technology that could be used to reduce the time that you require. So back to my simple scheme. So once you have the test result and the baby is confirmed to be HIV infected, then until ART is initiated, we have what we call pre-ART care. And pre-ART care may not be the right term, but for the time being, we use that one. During this period, we start cotrimoxazole prophylaxis, INH prophylaxis, prepare the caretaker and the child, if the child is old, for adherence and retention and so on. But there is one observation that we saw. If you look at that publication on the right side, it shows that there is a high loss to follow up when these children are not initiated with the ART. When there's 20% versus 0.8%. So with that, I'm sure that could be improved, but if we take things as they stand now, and if ART initiation could improve retention to care, and we know that it may improve immunologic response, there may be some reduction in OI infections and comorbidities with earlier ART. The possibility of ART initiation for all children under 5, especially programmatically, this could be make programs easier to implement within the MCH and the under 5 platform. So there is no hard evidence, clinical trial to show this to this factor, but the programmatic advantages are there, and the benefits may outweigh the risks. So countries like South Africa and Rwanda have gone ahead actually and implemented this policy. We need to review get some lessons from them, and WHO is upholding that for depending on the situation in countries, that initiation of ART, irrespective of CD4 count, for all children below 5 will come out in the coming recommendation. Now, one thing that can come out, like from South Africa, is like in South Africa, in the big centers, there may be a lot of kids that are waiting until CD4 eligibility is completed. So those kids now could be put, because South Africa has that policy already in place on ART, and the number of children on ART could increase. Now going to the ARVs for initiation of children, I've taken here kids below 3 years. These are the kids that have the highest mortality, as you know, higher viral load, and disease progression is very fast. They require a very effective ARV regimen to reduce viral load quickly. With systematic reviews done, there are 2 clinical trials that showed that a lopinavir-ritonavir-based regimen is superior to a nevirapine-based regimen, even in those kids, whether they are nevirapine exposed or not, or PMCT exposed or not. So with that, lopinavir-based regimens probably would be. There are other advantages of lopinavir in terms of efficacy, but as we can see in the next slide there are challenges of lopinavir-based regimen. First of all, if you look at the syrup, which is now available in the market, it requires cold chain, and that means that in rural settings that may be a problem. And there is also issue around palatability and so on. The solutions, which Raquel will tell us a little bit more later on, is that there are sprinkles coming up with better palatability and heat stable, and there is also the possibility of getting fixed dose combination with lopinavir or ritonavir under development, and that could help us resolve the issue of the cold chain and syrups and so on. There are also other possibilities that we have there, but which I will not go into. Now, for children 3 years and older, these kids can take efavirenz, and efavirenz is also the preferred drug for older children and adults. So in terms of going for harmonization with adults, the use of efavirenz would be useful. For children 3 to 10 years, the recommendation is, the preferred recommendation is abacavir plus Rit-C, but also you can use ADT plus Rit-C, and maybe tenofovir plus Rit-C. For adolescents, definitely tenofovir plus Rit-C is the preferred option. Now, the challenge there is tenofovir has bone toxicity for children, and that is worrisome. And the other challenge is that monitoring toxicity from tenofovir is also a challenge for the countries we're talking about. In the future, there is a possibility to make a combination of fixed dose combination of tenofovir, Rit-C, efavirenz, pediatric single dose, once daily dose FDC. That would be wonderful, because then we can have the same drug across all age groups, and makes it simple. The other advantage of use of tenofovir is, of course, when you have hepatitis B, HIV co-infection, and especially in adults when they have chronic liver disease, and this may happen in older children also, tenofovir would be the preferred drug. Summary, for the direction for the 2013 guideline is probably will say treat all children less than 5 years of age, regardless of CD4 and concurrent stage. Initiate children less than 3 years with a lopinavir-based regimen if possible. Otherwise, use the nevirapine-based regimen, and tenofovir will come as an alternative option. Now, with regard to the ARV formulations, I think the other speakers will go into detail the issue of market fragmentation. I will just give you two examples that we've been involved with. One is the Interagency Task Team for PMHCT, then the pediatric HIV subgroup, now is child survival subgroup, has come up with a list of ARV formulations that could be considered as optimal and then less optimal. So that grouping could help the pharma to produce more appropriate ARV formulations. We'll need to see how that had worked. Another example is, especially for countries that have really low HIV prevalence, I've been asked, for example, from Nepal and Maldives, they have quite a few number of children, and how do they get these drugs? You know, procurement becomes really a nightmare. So we or partners should help these countries to group themselves, and pool purchase orders, and that way they could negotiate for better prices and maybe more suitable formulations. I think we need to exploit that one. Probably that's the only way we have, and perhaps this could be linked to using the regional economic and political blocks that are there. I mean, for example, SADC for Southern Africa. An example that Raul told me from PAHO is COMISCA from Council of Ministers of Health from Central America and Dominican Republic, where they are trying to develop that strategy and could be a useful one. My last slide is scaling up pediatric ART. Once we have these recommendations, they need to be taken up, and we just using the treatment 2.0 framework basically need to optimize drugs and see as far as we can harmonize pediatric ART with adult ART, really. And diagnostics, again, we need to link up with B+, EID, and use decentralized pediatric HIV from hospitals, take them down to health centers, and maybe also some aspects could be taken to community level. Integrating pediatric HIV into MCH platform, adopting task shifting policy, upgrading infrastructure and human resource. And I'm in favor of trying to come up with a family-based approach for HIV testing and HIV care. Perhaps that is the only way for us to capture every child who is HIV infected. So thanks.
Thanks very much, Lulu. I think you raise a number of questions, and I think we shall address them during the question and answer. But I think the issues around issues like palatability, I think there'll be value in unpacking what that means for children. Any one of you who's a parent knows how difficult it is to get kids to take anything, much less to take these nasty medicines. So some of this detail, I think, would be good to just unpack what is meant by palatability, what is meant by toxicity, what is meant by, I think you were talking about fixed dose combinations, how close we might be. Is this something we're talking about 10 years from now? We're talking about the global plan has a deadline of 2015, so we're in a bit of a hurry. But in any case, so you've presented a lot of issues that I think will be very, very important food for thought. Our next speaker is Raquel Child. She's with Unitaid. She's the director of operations at Unitaid. And this is a group that is doing the work around trying to bridge some of the issues that, in terms of access and in terms of cost, that Lulu has raised. And she's going to tell us what Unitaid is doing in terms of what kind of approaches they have to help countries access treatment, pediatric treatment at affordable costs. So I'll turn it over to you, and I'll bring up your presentation.
Good morning, everybody, and thank you for inviting us to present how Unitaid is facing this huge challenge. As you may know, UNITAID is a very young organization that was created in September 2006 during the UN General Assembly in New York, following a political decision originated by the French President Chirac and the Brazilian President Lula. 5 countries are the founders of this organization. These are Brazil, Chile, France, Norway, and the UK. And the idea of this organization is to have market impact in commodities that for 3 diseases, HIV/AIDS, malaria, and tuberculosis, that in order to solve some public health problems. As you may see in this slide, what we do is to work with partner organizations, mainly UN and academic organizations, to assess the public health problems. And based in that and looking at which are the market shortcomings in order to solve the public health problems, we create innovative market interventions that will lead us to sustainable market impact, and having these commodities available and affordable, we could solve some of the public health challenges we currently have. I would like to say that the main tool we use to analyze the market shortcomings are landscapes analysis that are developed by the market dynamics team of UNITAID. And these documents provide a full range of information regarding all the shortcomings this public health area has in regards to the commodities required to face the public health problems. Another characteristic of what UNITAID does is, apart from working with the focus on markets, not in coverage of public health problems, and in order to be efficient, is working through implementers. We don't have projects, we don't manage projects at country level, but we do that through different implementers and partners organizations who are involved directly at country level and regional level in developing our project. Another trait that is quite important for UNITAID and that I didn't talk about is that we work with also with an innovative financing mechanisms. The fundings we manage come from, most of it come from a very small levy that is applied to air tickets. 80% of the fundings we manage comes from this levy that has been already implemented in 3 countries, mainly France, Chile, and Brazil. And and we also expect that the new innovative financing mechanism, the tax to the financial transactions, will also come to support what UNITAID is doing in order to solve some of the market constraints we have related to public health. Till now, we have worked in 94 countries, and 51 have been recipients of HIV fundings. Roughly $1 billion have been invested in for HIV. You see, our second most important actions are related to malaria, and then with a less amount of money in tuberculosis. We also have some cross-cutting programs that support what we do in the 3 disease areas. I would say one of the most important thing we do is to support the pre-qualification department of WHO, the medicines and the diagnostic pre-qualification department. So the medicines that are produced, the new drugs that are produced with our projects have the same quality. Most of them come are developed in as generic formulations, and so they are all pre-qualified, and so we get some equity, some degree of equity between the south and the north. Our top 10 countries who have benefited from UNITAID funding are all low-income countries, all African ones, as you may see in this slide. And as I already showed you, our main investment goes to HIV, in red in this slide. In the field of pediatrics specifically, in the first strategy we rolled out between 2006 and 2012, we have had 5 main projects. I would say the main project we have had is a pediatric antiretroviral project that that is currently being developed with Clinton Health Access Initiative. It's a project that was developed in 35 countries, and its objective was to get new formulations adapted to children. When UNITAID was born, we all agreed that no drugs adapted for children were available in the South, and not and neither in developed countries, because pediatric HIV was not a relevant disease in this part of the world. So one of the 2 first UNITAID projects was to start trying to develop new drugs and a market for pediatric ARVs, and I will show you some of the outcomes we've had with this project. It's a project that we are currently finalizing it, but with a good uptake of all what we've done by countries themselves, and also by some other partner organizations. The second, I would say, most important project we've done in this field is the prevention of mother-to-child transmission, jointly developed with UNICEF between 2007 and 2010, and it intended to increase the uptake of PMTCT, mostly in African countries, and also try to have some market impact, meaning bringing new drugs, and especially bringing prices down for this important public health activity. We have just started 3 new projects that relate to diagnostics. We obviously understand the importance of diagnostics in in starting treatment and adapting treatment to the needs of patients. We are currently working with MSF, also with Clinton and UNICEF in a joint project, and with FEI, a French organization, in trying to assess the feasibility of implementing these point-of-care technologies in different settings in low-income countries. We also have 2, I would say, 2 supporting projects that allow us to follow up what's happening at country level in terms of access to treatment, and also facilitating the training of people at country level. These are the CPP project and also the SRA project that is currently being rolled out in the West African countries. In terms of achievements, I don't know if you can read this from where you are, but I would say that for the pediatric ARV project, our main achievement, and we say impact, is that we have created a market for these drugs. This market and these drugs didn't exist before Unitaid came to work in this area. We have been supporting the treatment of almost 400,000 children in these 35 countries. And currently, from a project point of view, 35 countries have transitioned out from our funding to some others, meaning PEPFAR, Global Fund, and their own country budget. But we have some challenges in 5 countries that haven't been able to identify fundings to keep on treating the children and also keeping and making sustainable the achievements we've had in terms of prices and number of formulations. We have had some solutions, and obviously Unitaid will keep on treating and supporting these 5 countries till they find some new funding. And yes, I think I need to clarify that we, as Unitaid, our role is to boost the production of new drugs, to create new markets, but not to keep on financing countries in order to cover all their needs, because we see that there are a lot of market shortcomings and constraints and that need to be faced. And Unitaid, its role is to do that, and not, as I said, work as a traditional donor organization. For the SR8 and CPP initiative, we have also had some achievements that support all the pediatric treatments. They have raised the challenges we have in terms of avoiding stockouts and diagnostic at country level. And also, they have also allowed us to monitor the transition of these projects and the challenges countries are facing in terms of implementing the new drugs. Because one thing is to have the drugs at the central medical store, but a different thing is making them available at the healthcare centers. And finally, for the PMTCT project, we can say that this joint initiative with UNICEF originated an integrated approach to testing, treatment, and supporting pregnant women and their infants in a I would say, a high level and with a broad coverage. In terms of numbers, over 8 million women were tested and provided prevention, and about 1.5 million children were tested with PCR early infant diagnostic test in order to provide them also pediatric treatment. Just two selected examples of what we've done. As you can see in the left side of this slide, before Unitaid started working, almost 90% of drugs available came from originator manufacturers, and they were almost single-dose syrups. You can see, for instance, that for a 1-month treatment for just one drug, 16 bottles of syrup needed to be brought by women or men. Sometimes that happens. To home to treat children. Currently, we have only 10% of drugs coming from originators. Most of the drugs we procure, and most of the drugs that are available in the market come from generic manufacturers, and these are fixed dose combinations. And it's just one bottle of medicines for the month. And you can see also the price, how much it has changed. As an average, with this project, we got an 80% decrease of prices for a monthly treatment or yearly treatment for children. Now, thinking on where we are today, we expect that our new strategy will be approved, we'll get the final approval in the next board meeting in June. But we already have pre-approval document that includes six strategic objectives, and as you may see, the first two ones are related to what we're talking today. The first one is to increase access to simple point-of-care diagnostic, and the second one is to increase access to affordable, adapted pediatric medicines for the 3 diseases we take care of. Just to show you a very concrete example of how we face some of the challenges UNAIDS has stated. In the left side of this slide, we have what UNAIDS has stated as challenges and some of the solutions UNITAID is providing. In terms of formulations, last year, CHAI got the approval of ritonavir heat stable that is currently being used as booster for children. We are just starting a project with the NDI to produce new four formulations of antiretrovirals for children, some sprinkles and ritonavir granules. They will have tolerable taste, they will be affordable, they can be used for TB and also be used as booster. They will be affordable, no IP rights, and they will be produced by a generic manufacturer. In terms of challenges, just for you to look at the lower graph in this slide, the main challenge in terms of market is the tendency, the ideal tendency of pediatric HIV. We expect that in the future, less number of children will be infected, so markets and manufacturers may not be interested in producing these required drugs. And as a summary, I think that we have, from UNITAID perspective, we have some challenges in terms of short term. Is ensuring funding in the 5 African countries that still need funding support. We will keep on supporting them, but we need some other organizations to hand over this requirement. And the other challenge is to make really active the procurement antiretroviral working group that was created in 2011 by Global Fund, CHAI, and UNITAID. This is a working group that intends to gather all the information, all the forecasting, and hopefully most of the procurement required to face HIV pediatric treatment. We are working now with some other organizations that are part of this working group, meaning UNICEF, PEPFAR, PFSCM, and we expect that the bigger countries that need more this kind of treatment, like South Africa, would be part of this group in terms of, at least, of forecasting. So if we can share the need that the world or the South has in terms of pediatric treatment, we can negotiate better with manufacturers in order to get the better prices and the better formulations. And that means that in the medium to long term, we have the challenge of sustainability of what we've got now, to have this joint global health organization working together, how to get better early infant diagnostics, and see which will be the impact of treatment as prevention and the elimination of mother-to-child transmission in terms of market of commodities. Thank you for listening.
Thank you, Raquel. That, again, a lot of food for thought and a lot to unpack out of that presentation. I think some of the issues that you are raising in terms of, say, for example, point-of-care diagnostics, I think would be good to know a little bit more specifically what is up the pipeline, when it might be coming due, what specifically the products might be. I think it would be very interesting to hear a little bit more about how to, in the context of important programs like the one with CHAI ending, and how the future might look like. But I think this is going to be food for thought, and it's really, really good presentation. Thanks very much. Now we turn to low and concentrated epidemic settings, and we have the privilege of having UNICEF presented to us, represented by Dr. Malyuta with the UNICEF Geneva office, and he's going to share with us what they are doing to address pediatric HIV treatment in the context of low and concentrated epidemics in Eastern Europe and the region. So I'll bring up your presentation.
Thank you, Carlota. It's a privilege for me to be in this webinar and present the work which is ongoing on the concentrated and low-level epidemics. My presentation consists of the mix of slides which is UN data and data which I took from pediatric HIV workshops. There are 4 workshops already took place, and I really recommend everybody to visit the website so you can download presentation which has a mix of clinical research, public health data which will fit different needs of different professionals. In my presentation I will talk about 10% of global burden of HIV infection among children. So I'll talk about roughly 250,000 HIV positive children who live outside sub-Saharan Africa. And you will see that the issues faced by children in those countries, it's a pretty big range. So in terms, for example, of coverage of treatment, so it goes from 5% in Middle East to more than 60% in Eastern Europe. I will elaborate later on those. But first I want to start from industrialized countries. Less than 5% of children living with HIV in concentrated epidemic countries, a lower level, live in those countries, industrialized world. It's North America, West Europe. But why I'm using those countries in this presentation? Because epidemic largely started there. We know that the access to RV treatments started also there. And most experience accumulated today about treatment children with HIV are in those countries. And today those countries have an issues mostly around not the first decade of life of child, but actually it's about the second decade, where they're facing issues related to drug toxicity, issues of long-term adherence, issues for adolescents, and basically in those countries, HIV become among children is a chronic condition, which need to be managed as a chronic condition. And those are the issues. One of the key issues which were highlighted are mental health. Because in those countries we talk today about mental health. We talk about metabolic complications. We talk about bone mineralization and density related to toxicity. And look at that, this data from Project CASA, which shows, look at the prevalence of psychiatric diagnosis among HIV positive children. It's more than 60% of children faces issues with mental health. It's a huge number of children who suffer with anxiety disorders. So it's a lot of children who have ADHD. Those needs to be addressed. So if they are not addressed properly, so we cannot talk about adherence. So the next one, lipodystrophy. So look, children who've been long-term exposure to antiretrovirals. So in Italy, so it's up to 40% of children have issue of lipodystrophy. And think about adolescent who has lipodystrophy. So where the body, the presentation is so important, so that when you have the pressure from media from everywhere to be cool, and then suddenly so you develop lipodystrophy, gynecomastia in boys or other disorders. So that can really lead to adolescents stopping that, taking their meds. The other one, the issue of hypercholesterolemia. So you can also see marked increase of levels of cholesterol among children on heart, especially when heart is containing PI. And that can lead to long-term toxicities, so including heart problems in adults. And insulin resistance. So it's more than 15% of children could have insulin resistance. Those are the issues which we need to talk about. So, or bone density among boys. Look, so these are the differences among those boys, who want tenofovir. So, and that related to the bone density. And of course, the other issues, which are previously discussed, which are in the generalized epidemics, they are all applied to the epidemic and to treatment of children in the industrialized countries. But one of the lessons learned, which I want to highlight, is the approach to management of children in these countries. Because when I look at the coverage with treatment in the children in low and concentrated epidemics, I can see a big gap and difference between children coverage and adults coverage. So we see, for example, in Eastern Europe that more than 60% of children receive treatment. But when you look at the adults, it's actually less than 20% receiving treatment. The other regions has vice versa. You have more adults receiving treatment than children. And that's actually, it's about the switching of care must happen, so that we cannot just treat children as a separate. So it should be a family-based care. So what being achieved largely in industrialized country. When HIV-positive mother come to receive care, the question is asked, what about your children? Or if children with HIV come to receive care, treatment, we ask what happened to mother? How is your health? And that actually, we know that if we keep mothers alive, we keep children alive. So now we are moving to the Asia region. So actually, if we talk about the numbers in concentrated epidemic, that are the biggest numbers we come from. And here we can see the race from 2001 to 2009. From 100 to 160,000 children live in these countries. And the coverage with treatment it's about 40%. So we talk about 60,000 children, more than 60,000 children who are actually today not on treatment and who need treatment. And what are the issues? And again, this is a lack of identification and poor coverage during PMTCT, where mothers are not covered. This is a lack of PCR diagnosis, early infant diagnosis. And again, lack of pediatric formulations. And one of the other issues which have faced those countries, especially countries like India, where nevarapine-based regimen, single-dose nevarapine is still one of the main PMTCT regimen. So this is exposure to nevarapine during labor, and then potential for resistance among kids, which can lead to worse outcomes of treatment. This is a long-term response to antiretroviral treatment in Thailand. And we can see the mortality increased in case when the age is less than 1 year old, the CD4 less than 5%, and weight for height, the Z-score is less than 2. So this is something also, this is about signifying that it's how important to diagnose children early and ensure so that tests are available for children right after birth and within the first 2 months of life. The challenges of RT in children and in these countries is exactly the same which will been presented earlier. So exactly this is a splitting adult FTC tablet might not always be appropriate. So there are needs for also children needs this dose adjustment for growth and also the PIAP syrups which are today available. So have a needs refrigerator storage and also have a horrible taste. So this is exactly this burden of limited pediatric antiviral drug formulations. But one thing I must say, so that there is some advantage in countries, low and middle income countries compared to industrialized, because many of these countries has today access to generic fixed dose combinations, like what's been presented Triomune. So while in industrialized countries is all patent protected, and children have to take these tons of syrups. So at the age when they can already take pills. Moving to Eastern Europe and Central Asia. So you can see the dramatic increase in number of children living with HIV in this region. So it was less than 4,000 in 2001. So, and just 8 years later, it was 4-fold increase in number, in absolute number. And talking about this region, I must admit that so basically that the coverage with treatment is pretty high. It's more than 65% of children in need receive treatment. But when I talk about the regions of Eastern Europe and Central Asia, first thing which comes to my mind, so that among 25 countries globally with the highest burden multi-drug resistant TB, 17 countries are in this region. So, and tuberculosis co-infection is one of the main challenges which need to be addressed today. This is a slide from Ukraine, so we show that about 3% of HIV positive cohort of children in Ukraine, more than about 3,000, so had active TB. So which is dramatic difference. It's a huge difference between mainstream, between the general population and those kids. Because these kids live in the families, so where actually TB is very prevalent, so, and the household contact is the main contribution. And this is exactly what I mentioned earlier. It's about a need of family-focused approach and family-based care. Children cannot be treated in isolation. And this data actually consistent with data from generalized epidemic countries, where TB co-infection also on rise because child survival improved and the issue of TB co-infection become more and more relevant and more important, so it need to be properly addressed. So when we move to Caribbean, so we can see the numbers are pretty stable. So it's about close to 20,000 children living with HIV there. And the coverage, it's not that good. So it's only 25% of children in need receive treatment. But when I talk about Caribbeans, I want to highlight the issues of adolescence and the issues of adherence among adolescents and the challenges which they are experienced. You can see that, for example, one of the studies showed that the probability of virological response was low in those aged 6 to 12 and 13 to 17, but much higher in those who are adults. And this is a study which came from US and Puerto Rico. So, and that is basically described about what's happening with HIV positive adolescent and young people, so who acquired HIV perinatally. So, and actually there are a lot of them who are already sexually active. So, and only half of those who are sexually active actually use condoms. So many of them engage in unprotected sex. So their lack of adherence associated with initiation of sex, and also majority report lack of disclosure to their first sexual counterparts. So there are high prevalence of viral resistance among sexually active youth. So when we move to the next to the Latin America. So basically, its numbers also relatively stable, even so it's about 36,000, and also the children there. So because of Brazil, so we know also that expansion of access to antiretroviral treatment where it first started. So they also largely exposed to antiretroviral treatment. So and actually coverage, so in overall Latin America is 44%, so with great variations between the countries and within the countries actually. So, and we see that the issue of the side effects, for example, among adolescents like Brazil, it's up to 50% of adolescents are facing the issue of lipodystrophy, so which is something which need to be dealt with. So, and how to encourage adolescents have lipodystrophy to continue on their meds, so and not to stop taking them. This is the issue about the viral resistance among sexually active youth. So, and you see the prevalence of any resistance is 0.8. which is basically demonstrates because many of these kids, they went through multiple exposures. They started probably some of them from monotherapy, then it was dual therapy, later become HAART available. And so basically you see that all classes resistance have almost 20% of those children, adolescents. This is the data which is coming from Middle East. So so you see that the numbers also on the rise is 3 times increased children living with HIV compared to 2001. So, but when you look at the coverage, it's less than 5% are covered, which is very low and shows basically lots of stigma surrounded HIV in this region. So so that it's go just beyond the only issues of care, but it's also to overcome the stigma and getting children to care and getting their parents to care as well. So this is the data from Oceania, and basically, so you see also the children living with HIV, is on rise, also 3 times. So this is what I want to highlight. This is, I think, it's the last slide, so that the issue of pediatric HIV is a global issue, and we learn from each other globally. So we learn from the nurse. We learn from North-South cooperation, from capacity building. So, for example, in Eastern Europe, we've been engaged very successful in capacity building of providers. In Eastern Europe, by providers from Western Europe, who come and do workshops for referral care providers and teach them how to deal with the complicated issues of management of basically management of children with chronic care lifelong. So basically how to prepare children transitions to adolescence, disclosure of HIV status, how moving kids to adults clinics. So all those things which are today become very relevant. So in many countries the issue of kind of the first line treatment become kind of less relevant. So today we really talk about kind of treatment 2.0, treatment 3.0 even, about more complicated cases and management. So which is about a balancing between access to care, improving the access to care, and also improving the quality of care. So that's the end. Thank you.
Thank you very much, Ruslan, and I really appreciate that you took us around the world, because I think it's really fundamental that we have a good understanding on some of these differences. And I think as you make the point that a lot of progress has been made there, and so these are important lessons that we can be drawing and anticipating. I think any one of us with teenage children, or any one of us who, it's just the whole sensitivities around physical appearance for young girls or young boys is really going to be a major challenge, I think, and one can understand the psychological issues associated with that, to set aside the clinical issues associated with resistance and so on. Okay, so now we have a lot to discuss, I think, now. Celeste, I don't know how you want to proceed. I was going to suggest that maybe we take 3 questions from people in the room, and maybe Celeste, maybe you can add a couple from the, is there anybody online with a question yet? Not yet, okay, well, they'll come up. Maybe if you just, any questions, I'll just take the first 3 or 4. I'll start with back there, the gentleman over here. Was there another hand on the left? Okay, we'll begin with you. If you don't mind, just introduce yourself and then ask your question.
Maybe it's better to go in front of the camera. That way people.
Good morning. My name is Raul Gonzalez. I am working in WHO HIV department as a pediatric HIV treatment and care advisor, and brand new, therefore you don't know me. I got a question for Rachel. Thank you very much for your presentation. And you said you were making some things about second line for pediatric HIV treatment. I mean, I guess that you're assuming that first line is a nevarapine-based regime. Now that things are moving, and we are going to consider lopinavir-based regimes as first line, have you had any thoughts about the second line for this, suppose? Thank you.
Yes, Lisa Nelson from the HIV department at WHO, and thank you to everybody for excellent presentations. And I think you rightly highlighted all of the issues with diagnosing infants and young children. But we know, as you said, 3.3 million children are already living with HIV, and I think we also need to consider better case-finding strategies for those kids who are already infected.
Any other question in the room? Mary?
Thanks. Yeah, Carissa actually asked me to make an intervention on the data use, so I'm going to make about 3 points here, if that's okay. The first point is to think about, this whole conversation starts around coverage and the difference in coverage between children and adults. And it's important for us to think through what are the challenges with understanding coverage. So the numbers for the number of children who are receiving ART aren't so challenging, but the number of children in need of ART are very challenging. The first reason being the guidelines are changing, which is a good thing. We want the guidelines to improve, but we need to be very aware when we're looking at data that when you're comparing coverage from 2009 to 2011, there's a different criteria of who was eligible. So just something to keep in mind. The second point, and this comes very much to Ruslan's presentation, is we have a lot of challenges in estimating the numbers in need for concentrated epidemic countries. And if you think back, how do we calculate the numbers in need? It's those women who are pregnant, who are HIV positive, giving birth to those children. Well, how do we know the fertility rates of women in concentrated epidemic countries? They're primarily sex workers or partners of IDUs or or IDUs themselves, or partners of MSM. They have very different fertility levels. So it makes our spectrum models of those in need very, very challenging. So the next point I wanted to make is that and this has been made by a couple presenters already, there's a lot of challenges with getting children testing. Right now, the level of coverage for EID at 2 months, or early infant diagnosis, is about 30% in the priority countries. So those are the countries that are getting a lot of PMT-CT attention right now. So we've got huge strides to make in terms of getting the diagnosis out, but what wasn't mentioned in the presentations is the need to continue testing until breastfeeding is over in breastfeeding countries. And we're really missing that right now. And so to try to predict what our need is or what coverage is and not have the testing there is a real problem, real challenge. And then the final point was just to say, yeah, the whole adolescent challenge, and with some children who were actually infected through PMT-CT 15, 20 years ago are now coming into the adolescent ages. They actually haven't had sex, but we need to actually be testing them for HIV because they're growing up with HIV. And so to understand what's going on with adolescents and to get adolescents who haven't had sex to start testing is a very challenging programmatic thing, but something we need in order for understanding what's going on with our PMT-CT coverage. So thank you.
Thank you, Mary. Do you want to ask a question?
So thank you so much for excellent presentations. Shirin Haydari from the International AIDS Society. Yes, I realize the majority of the discussion is, of course, around the prevention of mother-to-child transmission, and rightly so, due to the necessity of that. But there is also studies about outbreaks of pediatric infection through iatrogenic infection, specifically in Central and East Asia. And I was wondering, do we actually know to what extent we have those outbreaks and the prevalence of HIV infection among kids that have not been infected through mother-to-child, but rather through other routes, and do we have any interventions to kind of control that epidemic?
Okay, excellent. I think maybe we can take some responses. I think there were some questions for Lulu, as well as questions for Raquel about the first line, second line drugs available. So Raquel, do you want to go first?
Okay. Thank you, Raul, for your question. We have started working with first-line drugs, and as you may have seen in one of my last slides, most of them have moved from nevirapine, and that's what we're currently doing and supporting. I would say our decisions are generally based on WHO guidelines, WHO, UNICEF, IATT guidelines. So currently we are waiting for the decisions that will come from you and to see how we're going to move in the coming future. Maybe we'll have a new call for proposals in order to face the new requirements that will come out from the technical organization. I think that's a more concrete thing I can tell you currently, because it depends on you and different implementers that will be interested in developing the new drugs or the new formulations that will be required as second-line drugs in the future.
I think, Lulu, there was a comment also from Lisa, but I think it was more of a comment, but I think it might be good for you to respond to that. Any other questions?
No, I think I will not comment on the comments. They are valid comments. I want to say about the estimation issue, because I think it's true when we changed the guideline in 2010 to treating all kids below 2, then suddenly the coverage actually went down, and we kept with that number now. And now with the new guideline, it's going to also, so that the percentage actually goes down. So there must be a way of getting the absolute number of kids who are on ART. That may be the more certain one that will show us that, in fact, more children are being treated. I think that's the only one that I need to comment upon. My presentation on HIV testing is not complete. In fact, I didn't realize the organizers were so generous on time. I tried to stick to 10 minutes, so I've dropped a number. But it's true that testing has to continue until breastfeeding is over, and that's very important, and probably the more difficult one, because you will not find those kids.
I probably will comment on the nosocomial outbreaks in Central Asia, and it's not only Central Asia; it's globally happening. So this is the outbreak. I want just to point that those outbreaks, they are not isolated. They're always happening in the context of the system where they happen. So if we look at Romania, the nosocomial outbreaks, where more than 15,000 children were infected with HIV, because of microtransfusions of blood, that's happened in the context of their own policies, which were kind of microinfusion of blood, which was untested for children to prevent malnutrition or treat malnutrition, and that's what happened there. So later on, Central Asia is the context you have, so that quite often you have hospitals where you have no running water. So you have shortage of supply of of equipment, medical equipment, syringes, etc. So, and of course, I mean, so the health system overburdened, so, and then this happens, so that children get infected. It's really kind of what we try to work. So in one side, so of course, we try to stop, so basically this to happening, so in the healthcare institution, because this is absolutely unacceptable. In the 21st century, children get infected with HIV in hospitals. From the other side, so we try also to make sure that children get diagnosed early, so to start treatment. And one of the tools which we introduced was actually this IMCI HIV model for concentrated epidemics, where we teach primary care providers about the signs and so what need to do to first identify that this child who attended your primary health care setting might be HIV positive, so that these symptoms might be like growth delay or kind of frequent ear infection. It can be linked to HIV. So do HIV test it, and then you have the algorithm what to do next. So, but again, it's a big challenge, of course. I mean, it's just to face that. So, and it's really needs to have multiple partnerships, so to work together. So, and in Central Asia, we build those partnerships with Asian Development Bank, with World Bank, WHO, so to build basically systems on the quality of care where nosocomial transmission of HIV and also other diseases, including hepatitis or even bacterial infection, will be stopped, so and will contribute to better health outcome for children.
I think we can also ask some questions. Actually, it's very important, Ruslan. I mean, we wanted to have the English version of your HIV material because we got the Russian version.
Right.
And we've been asked by Asian countries actually to get something simple in English. So it would be nice if you can share with me those materials. There are, I mean, you talked about Asia actually, but you didn't mention about that. So that would be very useful. A question for Raquel is, now that we have moved to PI-based regimen for younger infants, and you mentioned that DNDi, you're working with DNDi to develop a fixed dose combination of lopinavir, ritonavir with bacavir and 3TC. That fixed dose combination, would be very important, given that the current syrup, the palatability is so bad, and as I said, the cold chain requirement is also will not allow us to decentralize into rural places. So what is the timeline for that work? I mean, do you have some ideas?
Thank you for the question. We have just started this project. It was approved by our board in last July 2012. So we expect it's a 3-year project. We expect that in the first year we'll have the drugs produced, but then there is all we have clinical trials, we have pre-qualification, and so we expect that in 3 years time they will be available to be commercialized. Yeah, I know it's not tomorrow, but it's the day after tomorrow. Yeah.
I know it's almost 2 o'clock. Is there any questions online? Okay. Well, it's good that it's that clear. I do have a question, a very more of a practical question. So today you're talking about fixed dose combinations, basically, so that today, if a mother goes and is given the prescription for her child in Ethiopia, what exactly does she take home? When you talk about the burden, the syrup burden, can you translate that in English? What exactly does she take home? How many bottles does she take home? When does she have to come back for some more really, really practical issues that women have to face?
So I think you're referring to the PI, lopinavir, ritonavir, Kaletra, which in terms of, it is going to depend on the on the weight and the age of the child, but it's enormous. I mean, for 1 month, they take really, large number of bags. And I think that's the kind of the volume issue. It's what we saw more importantly is the child not taking it. The test is so difficult to take that we worry about taking the appropriate dose of that child. So those are two issues that we have. In the guideline, we state, because we are so concerned about this and also the cold chain, that if actually the health worker feels that the child will not be able to continue with Kaletra, then nevirapine is still an alternative. It's a weaker drug, but you have also dispersible fixed dose combinations which they can take. So that option is always there.
And the last, I have a question for Raquel as well. The point of care diagnostics that you're anticipating, can you give us a timeline? When might be something coming up, and what will it be?
Yes, I knew I had that pending answer. Yes, these are also, these 3 projects that I showed in one of the slides have also just started. As you may know, currently there are some point of care tests available, mainly for CD4 count, not as much for viral load or for EID. So what we are doing in the three projects is for one of the projects for MSF is testing what is available currently or will be available in the market in the next few months in different healthcare settings to see which is the best algorithm and which test will be best fitted for different contexts. The other, the Child UNICEF project will start analyzing the market conditions, which are the characteristics of the products that will be available in the coming years. And the FEI project intends to develop semi-point of care testing in 4 West African countries. The other ones are more in the East African countries. So in practical terms, for us, it's some of them, some outcomes will be, and some products maybe will be available in a couple of years, but I would say in 3 to 4 years, EID, CD4, and viral load point-of-care diagnostic will be available. We will support, we also have what we call market entry projects. We will start supporting some companies that are producing, and some academics, academic institutions also, that are just starting with the production of new technology. And that will take maybe a longer time to be available as real products at market, with all the requirements, trials, clinical trials, pre-qualification, regulation, so on and so forth. Yeah.
I don't know if there's any burning question, and if there isn't, I'd just like to thank the presenters for, I think, what you'll agree was a very useful discussion. Thank you for your very practical questions, very important insights as well. I know we've got some people on the web, so I'd also like to thank them for their participation. And again, to thank Celeste and Michael, who has just left, for coordinating and organizing this seminar. I don't know if there's any follow-up announcement you want to make about our next seminar, Celeste, but I'll just hand it back over to you. And thank you very much, everybody. Thanks.
For now, there's no specific seminar yet that's scheduled, but for sure in the next few months we'll be sending announcements by email like usual.
Thanks again, everybody, and have a good afternoon.
Thank you.